Welcome. This week we're doing a little different, moving on to the next block, and I'm going to be doing so. How I wanted to look at it was, how do we approach the difficulty breathing or acute dyspnea, respiratory failure? This first week we'll kind of just do an introduction. We'll talk about what patients look like, how do we approach them, and then next week we'll move on to more of the actual procedure, the technical aspects of intubation, and then we'll move on to difficult airways and then vent management, complications from intubation, those sorts of things. Are there other people in this video? Is there anybody here? Hello?
I see two other people on the call.
I know. Okay. Well, I'm gonna keep going. Okay, that sounds good. I just didn't know. I saw somebody walk away, so I was making sure I wasn't talking to myself. So this week we'll start with the difficult airway, like I said, or approach to difficulty breathing, respiratory failure. So we'll kind of just jump right in. And then, as always, if there's any questions or cases that want to be brought up, please feel free to jump in at any time. And then you can send over questions in the chat as well. So, airway is something that we all know. We see this a lot in any emergency department in the United States, over in Vietnam, and as ER doctors, we're kind of the experts of airway. So this is stuff you know and should be kind of a review, especially causes of dyspnea. When you see somebody that's dyspneic, if you've seen them before, if it's a patient if you can look up their chart, that helps drive you. But if it's not, if they're at first undifferentiated, I like to kind of consider what could be the cause. There are a few main kind of categories that we can go into, and the primary being pulmonary. So is their trouble breathing predominantly coming from a pulmonary cause? And some of the causes are, COPD, PE, pneumothorax, along with COPD, asthma. Is there an obstruction that's upper airway? Is there an oral swelling? Is there somebody having an anaphylactic reaction with swelling or wheezing that's causing their dyspnea? Pleural effusion, ARDS, which we can see later and we'll talk about more in later weeks. Is it cardiovascular? A lot of times cardiovascular presentations or complications are going to manifest as difficulty breathing. So is somebody having an MI? Are they in decompensated heart failure? Is there fluid around the heart because of their heart failure? Have they had some sort of flash pulmonary edema? And then some of those, arrhythmias, cardiomyopathies, valvular dysfunctions that when they're more severe or they've been going on for a long time, they can cause difficulty breathing. And there's sort of the crapshoot or these just other causes, something that is just something besides cardiac or pulmonary. Usually you can see the list: sepsis, anemia, ascites, anxiety, neuromuscular disorders. And those usually have to be pretty profound or severe if they're getting to the point where they're causing severe respiratory distress, but they can cause that. And just something that you always have to keep in mind when you're assessing these patients. So the presentation, somebody short of breath, they're going to be short of breath. This is fairly obvious, but sometimes it can manifest itself quickly. So people that present with just a little bit of tachypnea or complaining that you see them, they're breathing a little fast, they can progress fast. So I like to talk about it, are they tachypnic? Are they retracting? Meaning, can you see their ribs when they're breathing, or their clavicles? Those sorts of things. Is somebody gasping for air? Are they panting? Those can be sign of more progressive or severe dyspnea. And then finally, when we start to see them really bad, they can have altered mental status. Sometimes when somebody has had difficulty breathing for a long time, they're really fatigued. So you may not see that tachypnea or the chest retractions because they're so tired out, they can't manifest the energy to take a big deep breath. So really what you can start to see is an altered mental status, or you can see somebody that is almost in cardiac arrest or pending cardiac arrest. They're cyanotic or they're apneic. They're not breathing at all. These patients are sick, and our sick patients, when we see them, it's often good to just do this in a very systematic way. For some people, it's, airway breathing, circulation disability. These are these sick patients you go through in that way so that you don't miss anything. So you're not missing other causes. Is there something when you're talking about airway, when you're looking at these patients, is there something around their mouth? Do they have oral swelling? Do they have that lip swelling? Is there stridor? Is there something local that's causing that? Or is it lungs? Do they have a pneumothorax? Do they have wheezing? Something else that is causing that dyspnea. Circulation, if there's anemic, somebody has, this arrhythmia, if they're losing blood from somewhere, and then disability. And for some, that's just looking at, is their dyspnea profound to the fact that it's causing altered mental status. Along with assessing the airway, which we will talk about at length this kind of block and starting today, other things that can be going on while you're dealing with the airway is getting labs, a blood gas. Not sure if you guys do venous or arterial blood gases, but getting blood gases is really helpful. Seeing a pH, the PO2 and the PCO2 can be extremely helpful when you assess these patients to see what we need to do. It can also be good to get a baseline if you do any airway interventions so that you can see if your interventions are effective. Getting immediate glucoses, and then CBC, CMP lactate, troponins, D-dimers, those other tests that will help us once we have the airway in place and we get that immediate concern. How do we make them better? How do we bridge that airway, or what else can we be doing? The ultrasound, this is the patients where that ultrasound, that rush exam can be really helpful. Also looking for pneumothorax, pleural effusions, especially, sometimes you can't get a chest x-ray. These people can't lie flat. They can't sit up. They're not going to take a big deep breath. So your x-ray is not going to be great, or you just can't do it. You can't leave that patient enough even for them to get the x-ray. Definitely on these people, CAT scans they have to wait. They can't be done. It's a good tool if the patient is not sick enough that they can go to CAT scan, or once you get the airway. But on these ones, the ultrasound and skills in ultrasound are really valuable in helping you diagnose, figure out what airway is best, and start your adjunct therapies. So moving on to the airway breathing portion of it, the therapy and what you can do. Aside from intubation, there's a lot of things we can try first. There's low flow oxygen. That's just putting a nasal cannula right on the nose. That usually patients will tolerate up to 6 liters of nasal cannula. You can go a little higher if you have to, if you're pre-oxygenating. Much more than just that low flow, much more than 6. It can be cumbersome. It hurts the patient, and it can also it doesn't increase ventilation. So you're just blowing oxygen at them. If they have poor ventilation, then these patients can become hypercapnic because you're just giving them oxygen without changing ventilation. They build up CO2. You can, along with that, put on a Venturi mask or the non-rebreather masks. Those can go up to 15 liters. Same thing with those. You have to be careful if you're just putting a non-rebreather on. It's not a great permanent solution because you give them oxygen and you improve oxygenation, but you don't improve ventilation, meaning converting oxygen or the CO2 to and oxygen and CO2. So you can't expel the CO2, and that can build up. A lot of the respiratory issues like COPD or asthma, if you build up the CO2, that can worsen those disease processes, and you can make your patient confused, altered, and then that even further diminishes their breathing. With these ones, just looking at it, they're usually 60% FiO2. That's just something, and you can't really titrate it. So you can't go down from that. You're kind of stuck at that. The next one is high flow oxygen. And I'm not sure if you guys have that. The high flow oxygen is a great, I hope you have it. And they use it a lot in children. So it's a little bigger nasal cannula. It'll go in, it goes right into the nose, and it gives you high flow. This oxygen is usually humidified, so patients tolerate it a little bit better because it's flowing at a higher level. And we'll talk, I have a slide on this, but it can actually improve your ventilation a little bit. There's non-invasive positive pressure ventilation, so continuous positive airway pressure, CPAP, or bilevel positive airway pressure. Then there's intubation and cricothyroidotomy. So kind of touched on it, but the high flow is delivering this titratable FiO2, so you can go from 21% to 100%. It's that humidified air, and it is providing that PEEP, so that positive expiratory and expiratory pressure. That PEEP allows the areoles, or the smallest parts of the lungs, to open up better. And when everything's open, it improves ventilation. So we're expelling that CO2. The high flow nasal cannula is really good. And a lot of people, in some of the sources, like I found this Floral Eye trial, found that it really should be first line for a lot of lung diseases because it was so helpful and really was good at reducing the need for BiPAP or intubation. The benefits to high flow over some of those other ones is that it's really well tolerated by patients. Even if a patient is altered or they just don't like it, you can put the high flow on them and they will do really well and they like it. It's really good in pediatrics because kids will tolerate that, whereas you can't always get them to put a BiPAP mask on, and then you're not having to intubate them. Same with asthma, because as there's such complication when we intubate asthmatics. If we don't match their respiratory rates, then they'll build up CO2, and those patients can then have a cardiac arrest or respiratory arrest from a buildup of the CO2. So this is a great adjunct first kind of line if you have it. From high flow, the next kind of stepwise would be some sort of non-invasive positive pressure ventilation. So two forms of that would be the continuous positive airway pressure, so CPAP. And CPAP is just kind of going to be a continuous one-time flow. It goes in. This is used for a lot of people in sleep apnea, because when you have sleep apnea, if it's obstructive sleep apnea, sometimes that's caused from a collapse of the airway. So by giving the CPAP, you're just helping that airway expand and open up with providing continuous positive pressure. It's also helpful in congestive heart failure, and numerous studies have showed that it's just as effective in congestive heart failure as BiPAP. That's going to be your patient who has decompensated heart failure that is either hypoxic or has pulmonary edema and is having some difficulty breathing. This CPAP can help open up the lungs. It improves how much oxygen they're getting. It also can help decrease pulmonary edema. By opening those airways, you're allowing for better gas exchange. The gas exchange is then helping your body expel that pulmonary fluid that's built up, and that can help the problem. There's also BiPAP, so it's also a positive pressure ventilation, but this is a little bit different. So you get this continuous baseline positive pressure, and we'd call that the expiratory pressure. But then you also have increased pressure when the patient takes a breath. So inspiratory positive pressure. So you have expiratory pressure and inspiratory pressure, hence why it's called bilevel. So just two types of continuous pressure. And this BiPAP has been great. I've talked to, in my career, I've always had BiPAP, but talking to some people that are older that didn't have BiPAP as readily available, say the intubation rates are so far down with the adjunct of BiPAP and having it readily available to us. BiPAP is great in patients with, it's good in heart failure. It works great. And it's also very good in obstructive diseases. So COPD, asthma. in these asthmatic patients and COPD patients, this can be a good bridge. If you're worried that you have to intubate the patient, then trying them on BiPAP can be fine. You can give them medications as well to help tolerate this better. So, an asthmatic patient, maybe they're not going to tolerate the BiPAP mask that well. You can put them on BiPAP as a bridge to intubating and maybe prevent the intubation. So when you do this, you put them on BiPAP, give them a medicine. I like ketamine in these patients. So put them on ketamine, have everything ready for intubation if you need it, and then hopefully you prevent that. The benefit is obviously not putting the tube in, not having to sedate them as much, letting them maintain their own respiratory drive, which is really good in these patients because then you don't have to take that component away from them and they can compensate. So it's a really good one. It can help get rid of CO2 because again, with that pressure, you're increasing the size of the areoles, which allows better gas exchange, expelling that CO2 and helping the problem. The patients that you cannot use BiPAP in is somebody who's really altered. So if somebody is just so altered, you can't really get them to cooperate with your exam. They're not tolerating the mask, they're somnolent. It's not a great idea to do the BiPAP unless you're completely ready to intubate and you want to try just while you get stuff ready. It's not a good idea on these ones because they can aspirate and they can't protect their own airway. If somebody has a ton of secretions, not good. The other thing to think about is if you just can't get a tight mask fit. So typically our respiratory therapists are quite good at least in the US, are quite good at addressing these people. But I've seen it, here I have listed as trauma or surgery around the mouth or face. The other ones I've had some trouble getting a tight mask is if somebody has a lot of facial hair. So a big mustache, a big beard, sometimes you just can't get a tight fit and it's never going to be very effective. When you do BiPAP, some patients will tolerate it well. They've had air hunger, they're struggling, so that you put the mask on them and they do really well with it, and that's fine. Some people just do not like it. And if you ever have the opportunity, I would recommend that you try putting a BiPAP mask on while it's on, because it's kind of, it gives you a good awareness and awakening. As I put one on, it's very uncomfortable. The air is just really forcefully coming at you, and it's good to try it, and then you'll remember when you put patients on it that maybe they need something. You can try a small amount of just like an Ativan or Valium. It's just a small little touch, and that's all some people need. Some people do well if you put them on a drip, so you can use a ketamine drip. Benefit to ketamine is that it's just a dissociative. You can do small doses, you can titrate up. It does not cause any apnea usually, unless you do really high doses. It doesn't cause that respiratory depression, so people are maintaining their own respiratory drive. And then there's some studies and some findings that show that it can also increase the size of our respiratory, like the small vessels of the arteries, and then small arteries and vessels within the lungs, and so actually make things better, especially in asthma. And then another medicine is Precedex. So Precedex or dexmedetomidine works well if you do a drip on these patients. So the next, if BiPAP doesn't work, is intubation usually. And with the intubation, that's what we'll talk about next week, is intubation. And we'll talk about that at length and kind of get into it. So I didn't want to do that this week. Along with your therapies and getting the airway and securing an airway, you want to think about what else can I be doing to make this person's breathing problem better. If it's asthma or COPD, you're doing nebulizers. You can administer a nebulizer through high flow. You can administer a nebulizer through a BiPAP or a CPAP, and then obviously through an endotracheal tube. So even though you secure their airway, you give them a BiPAP, you still want to be doing those things to help bridge them off of those more advanced, the airway. Steroids can be good in the COPD, asthma, and antibiotics. Is it going to help immediately? No, but eventually that is what some people are going to need if they have a pneumonia or a pulmonary infection. For heart failure or pulmonary edema, diuretics, if absolutely needed along those lines, you might think about some sort of dialysis or CRT if it's very severe. Then pain medication, sedatives, like we talked about, I just, want to emphasize those are important. And especially with the sedatives, sometimes anxiety, not being able to breathe, provokes anxiety for patients because it is nerve-wracking. If you can't breathe, you can't catch your breath, it's going to make you more anxious. And making somebody more anxious increases how fast they're breathing, increases their work of breathing. So it's actually helping to treat their respiratory illness by giving them some pain meds or some sort of sedation. And you're going to be fighting the patient less, and it makes your job easier and it makes the patient much more comfortable. On occasion, you will need IV fluids, or blood if the patient is having respiratory distress secondary to anemia or sepsis. And then do you need a chest tube or something surgical? So just everything to think about on these complicated patients. So that kind of wraps up the lecture portion. And yeah, we can move on and do some questions. And yeah, so first question. A 6-year-old female patient is brought into the emergency department for fevers and chills for 3 days. She is found to have severe sepsis secondary to pyelonephritis, and IV antibiotics and fluids are started. While awaiting admission, the patient develops acute onset of shortness of breath. Vital signs are BP 86/60, heart rate of 117, respiratory rate of 30, O2 of 88. Patient is on 15 liters non-rebreather, no improvement in hypoxemia. Stat chest x-ray is ordered. Which of the following is the best next step in managing this patient? A, IV steroids, B, nitro, C, positive pressure ventilation, or D, stop antibiotics? And then, yeah, if you guys want to just answer in the chat, which there's anybody.
Hello, I think the answer is C. I'm not sure.
Yeah.
Yeah.
Yeah, that's great. Yeah, if I don't know why the chat, if you guys all want to answer in the chat, but that is great. C, I completely agree. Positive pressure ventilation. So, we talked about this, we tried the low flow, that 15 liters non-rebreather, and the patient is still hypoxic with that. Do you think you know what that is based on the chest x-ray? Yeah, it looks like from that chest x-ray, this patient probably has some sort of developing ARDS or acute respiratory syndrome disorder or flash pulmonary edema. They had this antibiotics, fluids, and then now they're just getting a quick increase in the amount of fluid in their lungs. So that when you have that flash pulmonary edema, you get fluid in the lungs, you're not going to be able to just quickly fix the respiratory issue. You're going to have to treat them more aggressively. And positive pressure ventilation would be great on this patient that's still 88%, on 15 liters non-rebreather. So with this one, I'd probably put them on BiPAP personally, as opposed to CPAP, just with it being a little undifferentiated. CPAP probably work as well, but BiPAP would be good. All right, next question. 33-year-old woman presents to the ED in cardiac arrest. Husband says the patient woke up this morning complaining of some chest discomfort and having difficulty catching her breath. Upon standing, the patient had a syncopal episode, and that is when her husband called the paramedics. Her husband states that the patient has had no past medical history, and the only medication she takes is oral contraceptives. There's no previous family history of sudden cardiac death. The patient is an active smoker. Cardiopulmonary resuscitation is continued upon patient arrival to the ED. She is placed on the cardiac monitor, and during a rhythm check, the patient is found to have a bradycardic rhythm. However, she remains pulseless. CPR is subsequently resumed. Additional 1 milligram of epi is administered. Return of spontaneous circulation is achieved. EKG is performed, which reveals sinus tachycardia with a right bundle branch block and right axis deviation, but is otherwise unremarkable without evidence of ST changes. What is the likely cause of this patient's presentation? A, Brugada syndrome, B, hypertrophic cardiomyopathy, C, pulmonary embolism, or D, ST elevation myocardial infarction.
I think the answer is A. I'm not sure, but maybe C, but I choose A. Because she has sudden cardiac death, and the ECG showed that the right bundle branch block and the right axis deviation. I'm not sure about A or C, but I choose A. Maybe that.
I feel like maybe it's C, just because for Brugada I'd expect some EKG changes, but
yeah, so in this one, the answer is C. I mean, I see what you mean with the Brugada, and she did have this sudden death. This is one, it's tricky. You know, there's a lot in the question stem, and, you know, for us, there's a few things I think that would point it to being a pulmonary embolism. I kind of put this in there to remember, you know, we are talking about respiratory arrest and distress, but these patients are everything. Everybody can have but this would be a respiratory arrest. What we're looking like in the question stem, you can see she's taking oral contraceptives and she's a smoker. So those two things, a smoker and on oral contraceptives, just looking at the question stem would point you towards pulmonary embolism, because being on a hormone and being a smoker increase your risk for clotting. So there's one little thing. When you look, the other thing it's going to say is that the EKG, so sinus tachycardia, is a sign of PE. You get the heart strain, and the right bundle branch, a sign of right heart strain, is what that would show you there. So those are kind of the two things in that question stem that would point you towards pulmonary embolism. So the right bundle branch with sinus tachycardia. Like you said, the Brugada would be more, you know, there's usually, if somebody's Brugada, it's going to be a syncopal episode followed by a cardiac arrest, and you are going to see the EKG changes and some ST changes on that Brugada syndrome. And this one, you know, when we initially were talking about this block, it was going to be kind of ACLS with it, but that's just so broad and so much. So I thought it was better to just focus on respiratory arrest, airway. And with that, I wanted to throw in a few questions of cardiac arrest and especially pulmonary arrest. So really pulmonary arrest, which would be a PE. So kind of moving on, this question, a 14-year-old male with history of asthma presents with respiratory distress. On exam, vital signs are BP 98/65, heart rate of 120, respiratory rate of 30 breaths per minute, pulse ox of 85% on room air. Patient has 1 to 2 word dyspnea, diffuse retractions, inspiratory and expiratory wheezes. After first nebulized albuterol and ipratropium and steroid, the patient still had increased work of breathing. How should you proceed with treatment? A, low flow oxygen, B, intubation and mechanical ventilation, C, CPAP with ketamine drip, or D, high flow nasal cannula in addition to continuous albuterol. Anybody want to give this one a try? It's hard, and
I will choose the answer D, high flow nasal cannula in addition to continuous albuterol.
Anybody else have, you guys agree or anything different? I'll let you think about it for a second, but I agree. I think high flow nasal cannula in addition to continuous albuterol. So, this patient, you've only given him one albuterol and ipratropium, so he still has a lot of room to get albuterol. Like we talked about, that high flow nasal cannula, it provides some PEEP, so the positive expiratory pressure. And so it can improve the areolars, improve not only oxygenation on this patient that's 85% on room air, but also ventilation. It's a 14-year-old, you want to make him comfortable and make sure that he's doing okay. So the high flow is good. He's going to tolerate that usually pretty well. You can do the high flow and you can give albuterol at the same time, which is nice. And then I touched on it, but with asthmatics, so he's breathing 30 breaths a minute, and that means that he is still able to compensate. So his body is naturally breathing that high so that he's blowing off CO2. He can't exhale well, so he needs to breathe fast so that he can get rid of whatever CO2 his body is starting to build up. If you take somebody like that and you intubate them, or even on this patient, you give them too much ketamine or the CPAP, what can happen with that is, sorry about that. What can happen with that is you slow down their breathing. When you slow down your breathing, if you don't adjust it right, you don't set your ventilator right, you don't set your CPAP right, you can decrease how much CO2 they're blowing off, and you increase how much CO2 is building up in their system. That can decrease the respiratory drive even more, and that CO2 can build up so much and slow their respiratory drive down so much that they eventually stop breathing, and then you have a cardiac arrest. So these asthmatics are people, you got to try everything you can before you jump to intubation, and high flow is great option. So good job. Next one, 57-year-old woman presents to the ED with acute COPD exacerbation. Vital signs include a heart rate of 105, respiratory rate of 28, BP of 108/62, temp of 36.8, pulse ox of 93% on room air. She has diffuse inspiratory and expiratory wheezes on exam and mild subcostal retractions. She's placed on bilevel positive pressure ventilation without a significant change in her respiratory status. She begins to have increasing altered mental status. What is the suspected cause? A, acute stroke, B, hypoglycemia, C, hypoxia, or D, worsening hypercapnia. Does anybody want to give this one a try?
I think it's D, worsening hypercapnia with the altered mental status and the normal pulse ox.
Yep. Yeah, definitely. And this is just to highlight those things. So in this patient, she's failing bi-level positive pressure ventilation or BiPAP. It's just not working for her, whatever reason. She doesn't have a good fit of her mask. The settings can be off. Sometimes you put the settings too low. So she's getting that worsening hypercapnia. You can try adjusting the settings. So you can also just go right to intubation in this patient that now has altered mental status. So this would be a patient that you move on to your next step. And yeah. And last question that I already have the answer for you, but because I skipped ahead on accident, but that's okay. We can talk about it. A 67-year-old male with past medical history of COPD presents via EMS with dyspnea. Upon initial arrival to the patient's house, EMS noted he was in respiratory distress. Pulse ox was 75% and he had diffuse wheezing. They initiated albuterol and ipratropium breathing treatment, gave Solumedrol, and placed an IV en route. When he arrives to the emergency department, he is still in respiratory distress. He's breathing approximately 30 breaths per minute. He has supracostal retractions. On auscultation, he has diffuse wheezing. On stat venous blood gas, the patient is noted to have a pH of 7.1, a PCO2 of 95. You place the patient on BiPAP, but he is not tolerating the mask and appears uncomfortable. What should you do? So I kind of gave the answer away because I accidentally pressed forward too much, but give the patient a bolus of IV ketamine, and the dose would be 0.3 to 0.5 milligrams per kilogram of that initial bolus, followed by a drip while getting advanced airway equipment to bedside. So on this patient, he still has a PCO2 that's elevated despite having been already given albuterol, given Solumedrol. He isn't tolerating that BiPAP mask. So you can try that, the ketamine, but whenever I put somebody on a drip like this or give them a bolus, you got to remember that it may depress their respiratory drive enough where you have to then go to intubation. So if you do the drip and the BiPAP or the ketamine or Precedex and BiPAP, it is always good to then have all of your advanced airway equipment ready at the bedside. So have everything you need for intubation. Make sure your respiratory therapist or nurse or tech, whoever helps you do your airway or intubation, sticks around while you have this patient. Don't let them, do the BiPAP and then walk away. Make sure this is somebody they know they have to stay at the bedside at least for a little bit till you see that they're tolerating this sedation. It's not making them too tired or too somnolent, that then they become a risk to themselves by becoming an aspiration risk if they're altered. We talked about it, but ketamine is a great option for these patients because you're not diminishing their respiratory drive. You can usually still talk to them and talk them through breathing. And sometimes you can even help them a little bit with the ketamine. So that kind of wraps up for this week. Next week, we dive more into the actual intubation and RSI, indications for intubation, things like that. So please, any questions or comments from anybody? And you can always send me emails too. I know it's a lot. And like I said, this was kind of just a get our feet wet on the airway. And when we start talking about intubation, it can be, more stuff comes up. It's more interesting sometimes than these other therapies. But yeah, any questions? Okay. Well, if anybody thinks of anything or has cases, anything like that they want, you can always send it to me. And yeah, I'll see you next week. We can talk more about intubation.
Yeah, thank you.
Okay, thank you guys.
Thanks, Claudia.
Thanks. See ya.